The next vignette in our CTD-PAH series is screening mandates for patients with connective tissue disease, improving pulmonary arterial hypertension identification. My name is Dinesh Khanna. I'm a rheumatologist and director of the scleroderma program at University of Michigan, Ann Arbor, Michigan. Here are my appropriate disclosures. The program has been provided by North American Center for Continuing Medical Education and HMP Global Company, and it is supported by an unrestricted educational grant from Actelion Pharmaceuticals and Rheumatology Consultant. The learning objective for this vignette is to create systematic pulmonary arterial hypertension screening procedures for patients with connective tissue disease that incorporate current guideline recommended tools and algorithms. So let's talk about connective tissue disease and pulmonary arterial hypertension. As I mentioned in the previous vignette, pulmonary arterial hypertension can occur in different connective tissue disease, the most common being scleroderma or systemic sclerosis, but don't forget rheumatoid arthritis, MCTD, lupus, and other connective tissue disease. Unfortunately, many patients present with advanced symptoms, significant functional impairment, and severe hemodynamics at diagnosis, all poor prognostic signs and symptoms. Timely diagnosis via systematic screening of patients may help support early intervention, and I'll discuss quite a bit about that. And I'll give you an example. In 2015, our European colleagues, European Society of Cardiology and Respiratory Medicine, recommended annual screening using echocardiogram. However, I will show you that in early disease, echocardiogram may miss 1 in 3 patients with pulmonary arterial hypertension. What I want to take from this vignette is that we need multiple screening variables, such as detect algorithm, that includes echocardiography and is recommended for screening in patients with scleroderma-related pulmonary arterial hypertension with diffusion capacity of less than 18% and has been endorsed by the World Scleroderma Pulmonary Hypertension. Pulmonary hypertension is a frequent complication of scleroderma. I show you out here 12 different individual studies that report the prevalence of pulmonary arterial hypertension from 3.6 to 32%. When you do a deep dive, the prevalence on right heart catheterization, again, the gold standard for diagnosis, is approximately 8.2%. And when you look at the last bullet point, when you look at patients who are at high risk, have a diffusion capacity that is less than 60%, the prevalence is 19%. So you can think prevalence in a systemic sclerosis patient walking around, 1 in 10 risk of pulmonary arterial hypertension. If they have risk factors such as longer disease duration and a diffusion capacity of less than 60%, the prevalence is approximately 1 in 5 patients. Now, as rheumatologists, we are used to this historical survival data. And again, this is Reveal Registry. It's a US observational cohort. And what I'm showing you on y-axis is survival, and on x-axis is time from diagnosis. If we just focus on the 5-year survival, and this was published in 2012, the 5-year survival at that time in idiopathic PAH was 67% versus 42% in patients who had CTD, pulmonary arterial hypertension. Times have changed. I will highlight in this and different series and vignettes, talk about that event-driven clinical trials have shown that CTD-PAH patients may respond well to treatment regimens with upfront combination therapy. Let's talk about the role of functional class and the prognosis of scleroderma pulmonary arterial hypertension. On right, I'm showing you WHO functional class from class 1 to class 4. Class 1 are patients with pulmonary hypertension without limitation in physical activity. It's very rare to find a patient in this class if you're fortunate and you really truly need a screening tool to do that. Class 2 is slight limitation, class 3 is marked limitation, and class 4 are patients who are in right-sided heart failure. On left, I'm showing you survival in a UK multi-center registry. In patients who had CTD, pulmonary arterial hypertension, and were found in class 1 and 2, a 5-year survival is approximately 60%. If they came to you in class 3, the 5-year survival is approximately 30%. And if they came in class 4, the 5-year survival is 10%. What does it highlight for you? As a rheumatologist, as a primary care physician, it is paramount that we screen patients with scleroderma and systemic sclerosis and scleroderma spectrum to diagnose these patients early, because the functional class does have an impact on their survival. Let me give you another landmark trial by Marc Humbert and colleagues in France. What they did out here was a simple experiment. They instituted an annual echocardiogram in patients who had scleroderma in the French community. On the left, I'm showing you patients who came as part of routine practice. The patient had symptoms, the patients were in right-sided heart failure. And of 16 patients, I show you that majority, 87.5%, were either in functional class 3 and 4. On the middle part of the slide, I'm showing you the screening population, 16 patients again. Because the patients had echocardiogram, 50% of these patients came in functional class 1 and 2, a big shift towards right. And the last part of the slide, I'm showing you the survival rate. Patients who had screening, who had instituted screening and were treated aggressively, as shown in purple, the 5-year survival was 73%. What is very profound here and disappointing is the 5-year survival in patients who came through routine practice, a 5-year survival of 25% with a delta difference of almost 50% in 5-year survival. Now, there is lead time bias. When people are screened early, they're treated early. But when you look at the 5-year survival in routine practice, as I highlighted before, not much you can do for the patients at this time. So screening is recommended in all patients with scleroderma, and screening by definition, as highlighted out here, is to identify people who are at risk of health problem or condition so that an early treatment or intervention can be offered that can reduce the incidence and or mortality. And the statement is very valid for people with scleroderma. When patients become symptomatic, then they are not being screened, then you're doing a diagnostic workup. So I hear all the time, well, the patient has shortness of breath, they have lower extremity edema, they have syncopal episodes. Should I still screen with echocardiogram? The answer is you're doing a diagnostic workup, you're not screening at that time. Screening is not same as early diagnosis. Screening invites people who do not have symptoms to undergo testing, whereas early diagnosis is intended to detect condition as early as possible among people with symptoms. So please keep that in mind. So here is a depiction of echocardiogram. On left is a slide of a person with normal echocardiogram. You see the nice left and the right side of the heart. It's an apical view. You see on the left side of the slide, right ventricle. On the right side is the left ventricle. And on the right side is a patient who has significant pulmonary arterial hypertension with a mean pulmonary pressure of almost 90 millimeter of mercury. What you see is the dilated right atrium, dilated right ventricle, pericardial effusion. Echocardiogram is excellent for making a diagnosis of serious or severe pulmonary arterial hypertension. But I showed you the data that once you make a diagnosis when the patient is coming in right-sided heart failure, in my mind, the game is over. It's very, very difficult to treat these patients. Here's the current paradigm for referral for right heart catheterization based on my conversations with different rheumatologists and primary care doctors. We as rheumatologists or clinicians think of whether the patient has symptoms or not consistent with pulmonary hypertension. A big issue out there is that symptoms may not be present in patients due to musculoskeletal problems, or the symptoms may be due to ILD, diastolic dysfunction, deconditioning. So it's very difficult in a connective tissue disease patient to differentiate the symptoms are related to pulmonary hypertension or they may not have symptoms. We look at risk factors. Do they have limited cutaneous scleroderma? Do they have anti-centromere antibody? And then we do an echocardiogram. And most of the rheumatologists look at the conclusion. What is the TR-jet? What is the estimated right ventricular pressure, whether they have right ventricular dysfunction? And then we have a gestalt. We make a overall gestalt that whether we feel that the patient needs to be referred for right heart catheterization. There's no standardization. Each of us have a different feeling, a different thermometer who should be sent for right heart cath. If not, we continue follow-up. If yes, we send it for right heart catheterization. This slide talks about the false negativity associated with echocardiography. We showed that echocardiogram is a wonderful, excellent tool for diagnosis severe pulmonary hypertension. But is it a good tool by itself to detect early pulmonary hypertension? Here are the patients who had scleroderma, diffusion capacity of less than 60% and a disease duration of greater than 3 years, who had echocardiogram and right heart cath at the same time. Let's look at the performance. If your estimated pressure was less than equal to 30, which a lot of us would consider quote unquote normal, but remember it's a high at-risk population with certain characteristics that put them at increased risk, such as DLC of less than 60 and a longer disease duration. Echocardiogram missed 20% of patients who had pulmonary arterial hypertension. Let's look at a cut point of 36 millimeter of mercury. A lot of us think of this as a normal cut point. Echocardiogram missed 36% of patients with pulmonary arterial hypertension. And when you think about a much higher cut point of 50, where all of us would be worried, echocardiogram would have missed 63%. But if you just keep that in mind, scleroderma patient at risk variables such as diffusion capacity and a disease duration of greater than 3 years, echocardiogram by itself is not sufficient. When you think about screening a patient with scleroderma, I want to propose detect algorithm that is now available in US as an app on your Apple or Android phone. There are two components to detect, step 1 and step 2, and let's walk through that. Step 1 has 6 items or variables. First one is forced vital capacity and DLCO ratio. A disproportionate decline in diffusion capacity, as you all know, is associated with pulmonary hypertension. Whether the patient had telangiectasias or not, anti-centromere antibody, NT-proBNP levels, serum uric acid, which may seem odd, but it's a measure of endothelial dysfunction and right axis deviation on EKG. You need 5 out of the 6 variables, and it calculates a risk score, and it tells you whether echocardiogram is needed in step 2. If it says no echocardiogram is needed, then you're done with screening for that year, and then you can redo the detect score in the next year when the patient comes back. However, if echocardiogram is recommended, the step 1 risk score goes into the step 2, and we add the right atrial area and the TR velocity, and it proposes to do a right heart catheterization. Now, what are the advantages of detect score? A, it is standardized. B, it includes different items that are risk factors for pulmonary arterial hypertension, such as telangiectasia, such as anti-centromere antibody, such as right axis deviation on EKG, such as elevated TR velocity. Number 2, it is highly sensitive, and I will show you that, and that's what you need in a screening tool. And again, I want to highlight that there are 3 societies that have recommended that we should use multi-item variables to screen patients with scleroderma, and annual screening is recommended. So there's a lot of consensus amongst the cardiologists, rheumatologists, and pulmonologists to do that. Here's the data we recently published in Arthritis and Rheumatology that we have been working over the last 10 years. So let me start with the left part of the slide, and then I'll go to the right part of the slide. We screen every patient with systemic sclerosis that comes into our cohort, and we compared the detect algorithm with 2015 European Society of Cardiology guidelines on echocardiogram. When you just look at the detect algorithm, what you see are 2 bars which are 100%. The first in blue is sensitivity of detect, and the second in purple is the negative predictive value. What do you want in a screening test? You want a test to be highly sensitive and have very high negative predictive value. You do not want to miss pulmonary arterial hypertension. When you look at the second part of the slide on the left side, you see the blue sensitivity of echocardiogram of 80%. In other words, we missed 20% of the patients who had pulmonary arterial hypertension on echocardiogram. When you go to the right side of the curve where the diffusion capacity is greater than or equal to 60%, again, the sensitivity and negative predictive value of detect was perfect. Whereas when you look at the sensitivity of 2015 echocardiographic guidelines, it was 67%. In other words, we missed 33% in our cohort, or would have missed 33% who had pulmonary arterial hypertension. Now, there's a trade-off when you have very high predictive values, negative predictive values. The trade-off is low specificity or positive predictive value, as shown on the left and the right side, which are the middle, 29% and 20% for the detect and 57 and 24 for echocardiogram. We all believe that pulmonary hypertension is lethal. It's a progressive disease, number one cause of mortality, and we strongly believe in the recommendation world that the trade-off of doing a right heart catheterization and getting a normal right heart catheterization is worth the risk and the complications, although very low with the procedure. So I just wanted to share this data from our cohort. What about other CTDs? Screening is not advocated due to lack of precise prevalence. If symptoms, then of course you make that into a differential diagnosis and do appropriate testing. So on the left side of this slide, I'm showing you asymptomatic disease. Again, I'm repeating, it's somewhat repetitive, but I think it's very important. Screening asymptomatic scleroderma spectrum, annual basis. On the right are symptomatic patients, any CTD. Any CTD should be included here, and think about early diagnosis with right heart catheterization. So in conclusion, all scleroderma patients should be screened annually. Regular screening has been linked to better patient outcomes. Early detection of pulmonary arterial hypertension allows the disease to be treated early, and we discussed about the detect algorithm. And for the other CTDs, keep that in differential diagnosis and start with echocardiogram and other tests that we mentioned. Thank you very much for your time and attention.